The broadcast is now starting. All attendees are in listen-only mode.
Welcome, everyone. I'm so happy to see that we have nearly 500 people here in the room, and we're very happy that you've all joined us. I am Kim Newell-Green. I'm a pediatrician and a volunteer assistant clinical professor at UCSF and the chair of this speaker series. And I want to welcome you all to the first COVID Clinical Update Virtual Grand Round series, a monthly virtual grand rounds for the state's clinicians on the evolving understanding and management of COVID-19. This speaker series has been generously co-sponsored by California Health and Human Services Agency and the California Medical Association. Specifically, I'd like to acknowledge the vision and leadership of Dr. Alice Chen, who's here with us today. Dr. Chen is the Deputy Secretary for Policy and Planning and the Director of Clinical Affairs of California HHS, and also Dustin Corcoran, the Chief Executive Officer for the California Medical Association. We're also grateful to be joined in sponsoring this speaker series by the California Association of Physician Assistants and the Osteopathic Physicians and Surgeons of California. Finally, I'd also like to give a huge thanks to the steering committee and the planning committee, as we have a strong and diverse group of providers planning this speaker series who hail from academic medical centers, public health, and several large medical groups from across the state. I'd like to start by acknowledging the place that we're in. This is a very raw time in our country, for our world, and a particularly critical time as the pandemic spikes in California. As professionals and as humans, as parents, as children of our parents, as neighbors and communities, we've faced very unique challenges and stresses, as we all know. It's our hope that by creating this speaker series, it will not only be a place to learn content, but also to feel a sense of community with other healthcare providers as we face this unprecedented health threat. We aim to provide content that's actionable in your clinical practice as much as we can. And we also want to acknowledge the power of providers in helping to curb this threat by using our voices, especially in this time when our response to this disease has become highly politicized. As an example, physicians have been involved in recommendations for school reopening, by making videos about correct mask use, by writing op-eds or speaking at town halls highlighting the science behind our interventions. The same can be said of our partners in healthcare, physicians and assistants, and nurse practitioners. And so I thank you for joining us. I'd also like to really thank our speakers for joining us. Today, we're so honored to be addressed by a number of wonderful physicians who have very central roles in California's response to this pandemic. And I'm so grateful not only that they've taken the time during this very busy time to help the work they're doing literally around the clock for months now, and especially in the last days and weeks to help mitigate the outcomes of this threat for all Californians. We plan to assemble world-class speakers like these every month and are grateful for your continued attendance. Now I have to mention a couple of quick housekeeping items. This activity is eligible for 1.5 continuing medical education credits, and information about how to get those will be at the end. All of the speakers have noted that they don't have any relevant disclosures for the purposes of this presentation. We will be recording these presentations and they will be posted on our website, the website that's listed on your slide. So please do send the information out to friends and colleagues who might want to look at these afterwards. If you have any questions along the way, go ahead and type them into the chat box, and our CMA colleagues Lupe Alonso-Diaz and Juliana Hinch will be monitoring those questions, and we'll try to get to as many as we can at the end of the presentations. So now I'm going to briefly review our agenda, and then we'll go ahead and get started. We are going to hear from a number of wonderful speakers. Unfortunately, Dr. Mark Galley, the Secretary of California Health and Human Services Agency, sent his regrets at not being able to join us today. He's giving a press conference as we speak, but he will join us for future virtual grand rounds. To start off today, we have Dr. Alice Chen, who I've already mentioned, the Deputy Secretary for HHS, and she's also the Deputy Secretary for Policy and Planning and the Director of Clinical Affairs. Dr. Chen is going to talk to us about the phases and the history of COVID-19 in the state and the state's response to date, how they're responding now in the setting of this spike, and some of the data and metrics used for this. Next, we're going to hear from Dr. Erica Pan, and I'm particularly grateful for Dr. Pan for joining us, as I think it's her first or second day on the job as our California state epidemiologist. So we really sucked her in quickly, and she's going to review the current COVID-19 epidemiology. And finally, we're really grateful to have with us Dr. Sonia Angell, who is the State Public Health Officer and the Director at the California DPH. Dr. Angell is going to talk to us about health equity in the setting of COVID-19 and review some of the racial and ethnic disparities that we probably already know about, but give us more information and data about that so we can know what can be done to support these communities. As we wanted to craft this series, CMA had sent out a survey in May to get some data from providers in the state. So if we can advance to the next slide, please. About how many of our physicians were really encountering this. At that time, more than half of the physicians surveyed had not yet managed COVID-19 patients, and only 4% reported feeling very comfortable managing them. Next slide, please. Most of the people who at least filled out the survey, and probably who are here today, are in primary care or urgent care settings, but we really do anticipate a wide-ranging audience of specialties and hope to serve the needs of the whole specialties. Next slide, please. CAPA also sent out a survey of PAs. We can get you better data on this if anyone's interested, but in summary, we all can learn more about this disease. Next slide, please. And this is the patient care settings in which the PAs who filled out these surveys work in. Again, the biggest majority in primary care and urgent care. Next slide, please. So we're very interested in hearing directly from all of you on this call today regarding your experience with managing COVID-19 patients. As you can imagine, our collective experience is fluid and may increase with time as the disease increases. So we're going to release the survey now. And get your experience on that. So do the survey and then we will move forward. As you finish up on the quick poll, just as I said, we're offering CME for this series, and so we're going to show you the objectives for today's webinar. And then right after the poll is done, we're going to go ahead and, oh, here we are. So 68% of you here today do not have experience managing COVID-19 patients. So we still have a lot to learn, all of us. Okay, so let's move to the next slide. These are our learning objectives for CME. And then we're going to go ahead and I'd like to introduce Dr. Alice Chen, who I've already mentioned twice before. So we're very honored to have Dr. Chen here. Because of some funky technical issues, it looks like Dr. Chen is not going to join us by video, but we'll all hear her voice and look at this beautiful picture of her as she describes what's happening in California now. Dr. Chen.
Excellent. Thank you so much, Dr. Green. I just wanted to start by also expressing my appreciation to CMA, to Dustin Cochran, as well as to CAPA and OPSC for their partnership with the California Health and Human Services Agency on this virtual Grand Round series. I also wanted to thank our planning committee and the CMA staff, Lupe Alonso Diaz and Juliana Hinch, and in particular, our planning committee chair, Dr. Green, who's been really a central force behind making this initiative happen. As Dr. Green mentioned, we had initially conceived of the Grand Rounds in April when our cases were low and declining, but we knew that COVID would be part of our clinical landscape for the foreseeable future. And we wanted to find a way to support and be responsive to our state's clinicians in managing a disease where the knowledge base is literally evolving and changing every day, you know, depending on what comes out in preprints and in peer-reviewed journals. And given our recent increase in cases and hospitalizations, we're all the more committed to providing timely, practical information to help you care for your patients, and really look forward to hearing your suggestions for topics that would be most useful to cover. So today's is not a clinical presentation, but that will be the focus of much of our future series. Unfortunately, as was mentioned before, Secretary Galley can't join us today, as he's actually giving a press conference right now on our new testing guidance. And I'm sure there'll be lots of questions that will come up around that. We will likely have a session specifically around that later. However, we have Dr. Sonia Angell, our Director of Public Health, Dr. Erica Pan, our new state epidemiologist, who have both been really intimately involved with the COVID response. And we're planning to have Dr. Galley with us here in the future. So what I'll do is provide actually a brief overview of our efforts to date. And I'll leave it to Dr. Pan and Dr. Angell to share the data and analyses because they have just both a broad and deep understanding of what's been going on for the last 4 to 6 months. And I look forward to the questions and discussion afterwards. So it seems hard to believe that the COVID era in California is really less than 6 months old. We talk about COVID days being like dog years, you know, every day is a week. It seems like a very long time. It's hard to think about how things were before. Really, things started for us in January, late January, when our first known case in Orange County was diagnosed. And that phase, which I think of as kind of a pre-public phase, lasted until early March, when our first known death, we now know that there were previous deaths, but from postmortems, but at that time, our first known death from COVID and the state's emergency declaration that Dr. Angell had put out. That phase was one in which the public health community and a few select healthcare providers and hospitals were really pulled headlong into COVID, but for the rest of the world, it was very much, you know, tracking things through the news, but more or less life as usual. And that really changed dramatically in mid-March when we did our stay-at-home orders, first in the Bay Area, and then California being the first state to issue a statewide stay-at-home order. And again, a lot of this was prompted by following things that were happening in Italy and in New York, watching our colleagues being really overwhelmed in their healthcare systems and working with modeling teams, which, remember, at that time, we knew a lot less about COVID than we do now. We knew a lot less about what interventions might be effective in stemming the transmission. Some of those models were really quite dramatic, showing that our peak excess hospitalizations could be as high in the worst case scenarios as 10 times the number of hospital beds we have in our state. And that really prompted us to take dramatic action while we prepared for surge. So the initial models suggested that we would have this peak in late April or early May. We spent that time throughout March and April working with the federal government. You may remember we had the USS Mercy docked in Southern California. We stood up a new hospital, the LA Surge Hospital, which was an incredible collaboration with our colleagues from Dignity and Kaiser. A hospital that actually was prepared to accept 50% ICU and vented patients. In Northern California, we had Seton. We stood up federal medical stations across the state, as well as other alternate care sites. I'm trying to make sure that I think this is just technology. You're going to hear the dings here. What we realized was that our, stay-at-home order, or what people call non-pharmaceutical interventions, NPIs, really worked better than we had ever hoped for, and that we ended up needing very little of that surge capacity. Once we realized that, we really had to pivot to think about how do we reopen California under Dr. Galley and Dr. Angell's leadership. We created a roadmap with 4 stages. We created or identified key capacities that we needed to develop as a state around contact tracing, testing, hospital capacity, protecting the most vulnerable, and very importantly, data. And you'll see a lot of what we've actually been able to develop over the last several months, because without data, we have no idea where we're headed or whether the policies we're putting into place are having an impact. I do want to pause for a second and just note that we knew then, as we were starting to open, as we know now, that without a vaccine or herd immunity, as we start opening up, as we start moving and mixing, we will have more infections and we will have more hospitalizations. And our goal then and now is to really balance the harms from COVID infections and overwhelming the healthcare system with the harms of shutting down the economy and closing schools, particularly for our most vulnerable communities. We already knew pre-COVID that California has some of the largest income and wealth inequalities that feed into many of the racial and ethnic disparities that you're going to hear about from Dr. Angell. And we know that closing schools has a disproportionate impact on our poorer communities as well. So that next phase of reopening was really based on very specific sector guidance from the state. And just I'll note that one of the challenges of California is that we are really large. You know, the governor oftentimes refers to us as a nation state. We are large, diverse in terms of geography, demographics, culture, density. There really isn't a one-size-fits-all solution. And I think you'll see that when you see some of the data by county. And so as we started opening up, you know, as predicted, our cases started increasing, particularly among younger people who, you know, the good news is they're much less likely to become seriously ill or die. But on the other hand, they are a reservoir of infection that then makes other people more vulnerable, particularly our essential workers, our older people, and people with comorbidities. You'll hear more about this later, but we have been monitoring this process very closely from the beginning. As we started reopening, we have a county monitoring process. We have noted from the beginning, again, California is so large, we don't really have a single pandemic. We have multiple pandemics. There's Imperial County and the border. There's LA County, there's the Bay Area, there's Central Valley, there's a whole northern part of the state. Each of those areas has a very different dynamic and drivers and needs to be evaluated differently. So you'll also see some of the data that I think Dr. Pan will be showing is that over the past few weeks, I'm sure many of you have been following this, if not on our websites, through the news, that cases and test positivity have been increasing. So we have known that cases have been increasing for some time because our test volume has been going up. But more recently, over the last 3 to 4 weeks, our test positivity has gone up. And following that, hospitalizations and ICU census have all increased. And you should know that we monitor the data very, very closely, and that prompts us to take action. And so that's where you saw that on June 18th, we issued a statewide mandate for face coverings in public spaces. On June 28th, we closed bars in high-risk counties. July 1st, we closed certain indoor activities in high-risk counties. And then yesterday, we took the additional step to close bars and certain indoor activities statewide. Again, the whole point of this is to balance health and healthcare with the economy and education and take into account the diversity of California. We're trying to use the evidence to create what essentially is a new way of being, a new normal for the next foreseeable future, where we continue to avoid unnecessary mixing, where we can, we take things outside, wearing face coverings, practice physical distancing, and of course, always hand hygiene. I think I would echo Dr. Newell Green here, where I think as clinicians, as physicians, as physician assistants, and us, we really have a role in society in engaging our patients and community about the need to stay vigilant about these behaviors. Because again, until we have really effective therapeutics upstream, before you get to the hospital, before we have an effective vaccine, like this is what is going to keep our community safe and enable us to start doing some of our usual activities. In addition to that, in parallel, we've been working with our counties and hospital partners to ensure that we have sufficient capacity in the healthcare system and to care for patients. We're in very close contact, not only with individual counties, but with the California Hospital Association, looking at things both from a county, regional, and statewide perspective. And then very importantly, we're thinking a lot right now about how to better protect our most vulnerable. Again, folks who are in the essential workforce, people who are in congregate settings like skilled nursing facilities, prisons, jails, shelters. And so I'll just finish up by saying that over the course of the last 6 months, we've done a lot, and importantly, we've learned a lot. We are far from perfect. We are in the throes of responding to our recent increase in cases, but it's worthwhile to touch on how far we've come. And so to give you a few examples, testing went from an average of 2,000 a day at the end of March to more than 100,000 daily by early July. In terms of PPE, which has been a pain point across the board for healthcare providers and healthcare organizations, we've procured and distributed tens of millions of face masks, surgical masks, gowns, and gloves. We are stockpiling ventilators. We've developed the California Health Corps, and I'll just make a pitch here for those of you who are interested. We are activating that again. We had initially 90,000 people express interest. About 35,000 of them were healthcare professionals with licenses. Because we averted that initial surge, we only needed a small subset of them, primarily to serve as SNF strike teams. But with the ongoing surge and hearing from some of our hospitals the need to both care for COVID patients and addressed a lot of the deferred care that had been postponed during that initial stay-at-home order, we are looking for additional people for California Health Corps. We have, I mentioned the SNF strike teams, a real focus on skilled nursing facilities. Some of our data indicates that while SNF residents represent about 1% of the California population, they represent as high as 44% of our deaths. And so a lot of effort around infection control, universal screening and testing, and making sure that we protect those really vulnerable residents. We've taken down the LA Surge Hospital because it was a very costly endeavor, but we actually do still have many of our other alternate care facilities that are either in actually have patients there or are ready to be stood up in the event of a surge. We've done a lot of work around therapeutics, advocating with the federal government to ensure that we get our allotment of remdesivir, and using the California Department of Public Health database, laboratory database, to reach out to people who have had COVID to donate plasma for convalescent plasma treatment. And then lastly, we've developed a lot of dashboards that are available to the public. I would urge you to go to covid19.ca.gov, as well as the California Department of Public Health website. Both of them have a wealth of really useful information that you can track your own county and locality, as well as statewide data. So at this juncture, we know a lot more about the virus, including, importantly, the role of asymptomatic transmission, and that transmission is significantly reduced when outdoors. We know more about how to treat patients, deferring intubation until later. We have at least a couple tools now in our therapeutic armamentarium, namely remdesivir and dexamethasone. We are blessed to have a whole, some of the nation's and world's leading academic institutions who are doing a lot of the research on additional therapeutic agents, as well as additional therapies to mitigate the impact of people who have severe illness. And there's a lot we don't know and we'll only discover with time. And so I'll just finish by saying, the way we've approached our policy response to COVID is by constantly learning and adapting to what we discover. And I think that is in the best tradition of the medical profession of lifelong learning. So I'll pause here and turn it back over to Dr. Green.
Thanks so much, Dr. Chen. We're going to transition over to Dr. Pan, but first I just want to remind everyone that If you have a question, please use the question feature rather than the hand raise feature. We're not going to be able to respond to the hand raises. So, Dr. Pan, go for it. Thanks.
Great. Can everyone hear me? All right. Good afternoon, everyone. Thanks for the opportunity. And as Dr. Green just mentioned, my huge caveat around this is I did just start yesterday. Dr. Green swore me in as a state employee yesterday, and I'm honored to be here. My clinical hat is I'm a pediatric infectious disease doc by training, and have seen patients up until pre-COVID. And I came here from a local health department perspective. I was the Alameda County health officer prior to being here and worked there for about 8.5 years. So I'm mostly going to talk to you today about some of our data and actually show you, since this is such a rapidly moving situation in pandemic, some of the resources that we have so that you can follow along and just make sure you're actually aware of some of our different data sources and how those are evolving and looking. I just want to reflect a couple things before I dive into the data that Alice mentioned, which is, as mentioned, I think the public health community has been tracking this since early January. Many local public health departments, certainly in California, activated their public health emergency responses in late January. Just
I didn't realize that.
Reminder to please put your phones on mute. So many of us have been, at this since late January. Again, tracking, initially monitoring people coming in from Wuhan, China, and things like that. So it definitely feels like, as Dr. Chen said, dog years and COVID time. Next slide. So this is just sort of a banner that gets updated every day. This is from yesterday, but you'll see this on the website, covid19.ca.gov, and kind of a quick overview of our numbers. You can see this is, again, already outdated, but there was over 329,000 cases in California cumulatively, and that was an addition of 8,300. We'll talk more later about the age breakdown, but again, this is something you can see on our press releases and every day. The gender breakdowns, we'll dive into that as well, and fatalities. And then this dashboard also shows sort of our hospitalizations and ICU, both the lab confirmed cases and the suspected cases. And then again, there's a link here to the county level data, which I'll be showing you some different snapshots of different websites again. Next slide. So this is one of the dashboards that you can link onto, again, from that covid19.ca.gov website. And this, you can look at our overall statewide statistics. So just looking at the graph again, and again, and looking at the trends, which is really important. So over a one-day change, we had an increase of 2.6%. Over the last 2 weeks, we've had a 50% increase. And you can see that bigger dramatic sort of rise in the number of new cases really started around the end of June. Was kind of when we started to see this more dramatic increase in new cases. And then again, you'll see a fairly even split on the gender breakdown, female to male, and really starting to see more of the younger population. So 60% of our cases are in the 18 to 49-year-olds. And then looking at the death trend as well, there's actually some other graphs I'll show you that are a little easier to kind of see the trends. But again, just looking at like a one-day change and a 14-day change, this is where you can see that we had a 0.3% increase over the day there, and then, but a very concerning, an 18.6% increase in the 2-week change. And this is the data as of July 12th. Next slide. And actually, just to mention on that prior website, you can, again, look at positive cases, suspect cases, and deaths, and you can drill down by county, and it ranks them by the highest number of cases and moving down. This is actually another way of looking just at our map of total cumulative cases and looking at the geography of California and then the new cases. So looking at the map on the left, again, we sort of think about a number over 100 per 100,000 as concerning. And so you can see by the dark areas of California here that we have already an increasing proportion of counties that have that higher case rate. And then that's, again, the total cumulative cases. And then if you look at the map on the right, you'll see in the new cases in the past 2 weeks, again, so this is what is the case rate over the last 2 weeks, you'll see an even darker sort of increasing trend, which is very concerning. So that is what we are responding to, and again, led to the actions yesterday. Next slide. So this is another way you can look at testing. Alice actually mentioned this, but there are over 5 million total tests reported, 2.5% increase, and then the daily new test 14-day average is here on this website. So you can, again, continue to see the cumulative numbers of new testing and how much we've dramatically increasing our testing in California. And then the other indicator we look at, which of course has a lot of different variables as far as what is the actual capacity, what's the pretest probability, but an overall indicator that's helpful to follow the trends is what is the percent of tests that are positive that we're doing. So you can see very early on, right after the shelter in place or stay-at-home orders at the end of end of March, early April, when we had very limited testing, we were really limiting it to sick patients, that there was a very high proportion, around 40% at its peak of percent positivity. And then as we really ramped up the ability to test and more broadly testing, you can see that we've had different trends, and there's definitely a start to see an increased trend here over the last 14 days, around 7.4%. And we have some concerns, as I'll show you in another slide. Once you get to over 8%, that's another kind of flag that we have more concern about widespread community transmission there. Okay, so the next slide. So another way of looking at our maps, this is, just kind of, again, giving perspective. We have over 40 million people in California. And again, over the last 2 weeks, we've had 109,000 new cases and a case rate overall of 273 per 100,000. So again, we're concerned because over 100 per 100,000 is where we do have concerns. And then the number of deaths over the last 14 days is here. And again, another way of looking at the test. And then here also, you can see sort of a map of, and then I'll show you next, but here this is sort of the overall map of which counties are, hitting certain flags as far as certain indicators that we're watching more closely as a state and working with more closely, and or deciding upon certain interventions based on other indicators. And so for you as the frontline clinicians, if you want to see where your county is, you can go to this website and actually click down on your county to see where your county stands. So the next slide. So here is another link. This is actually from the CDPH COVID-19 website to link, and you can see what are these indicators we're talking about that put counties on or off this monitoring list. So it's different indicators looking at elevated disease transmission, increasing hospitalization trends, limited hospital capacity metrics. These are kind of the main 3 buckets that are putting people on or off the monitoring list. And it can be, we look at 3-day trends and 14-day trends with this as well. So as far as the testing capacity, we are concerned if there are less than 150 per 100,000 tests per day happening over a 7-day average. So you can see that as one indicator. And then looking at disease transmission, there's a couple different ways to slice or dice this. I mentioned the over 100 per 100,000 case rate over the last 14 days, or if you have a case rate over 25 per 100,000 and a test percent positivity over 8%. So there are 2 different ways you could be flagged to be on this list for that. And then for increasing hospitalization, right now our indicator for that is if there's an over 10% increase in the 3-day average of the lab-confirmed COVID-positive hospitalized patients. And this is based on the hospital bed polls that we're doing daily. And this is not necessarily new hospitalizations, this is how many beds are occupied that day and doing a 3-day average. So if your county has a more than 10% increase in that number over 3 days, that could potentially flag you as well as concern. And then looking at capacity, if there are less than 20% ICU beds available or less than 25% ventilators available. So just to kind of give you a snapshot of that prior map I showed you, shows you which counties are either on that list for 3 days or 14 days based on at least one of these indicators. And we have an increasing number of counties in that situation. Go ahead to the next slide, thank you. And then shifting a little bit to what we call the epidemic curve. So the way you're used to seeing the numbers and the data in the media and some of the flash points are new cases reported that day. From an epidemiology perspective, what we also look at is our epidemic curve, and when we're looking at smaller outbreaks, we always do this as well by the date of illness onset, or now that we're seeing more and more patients without symptoms, we are just using the date of test as a sort of guiding rule. So this is our epidemic curve for California. That highlighted yellow bar is where we, of course, see some time delays, and I'm sure this question will come up. We know, especially recently with our increased testing capacity, there's also been increased demand and slower turnaround times. So there's certainly a delay in reporting, so there's going to be some lag time, especially in that window that's highlighted here. This may be an early sign that, maybe that peak was the end of June and maybe the trend was improving, but, we definitely need more time to tell, and there could be, I think in general we anticipate peaks and valleys over time, but this is how we try to figure out, the actual disease, when were people ill or when were they diagnosed, as opposed to when were they reported to us, to try to sort that out. Next slide. Similarly, when we look at deaths, there's a much longer time delay in reporting of deaths as well. So this graph gives you the number of new deaths by date of death. The blue bars are the actual numbers that day that were reported, or the date of death reported, and then the trend line of the 7-day moving average. And so again, there's a time lag and longer than we see even with new cases. But there may be, it was the highest as far as the 7-day average earlier in April, which was more of our peak, and then there may be, but again, we are only cautiously looking at this. We can't say for sure if this is a decreasing trend, but our hope is that that is, but again, it could be that this is a timeline with our other increase in new cases. Next slide. And then this is an interesting one, just looking at sort of different trends in age of cases and hospitalizations and deaths. So the upper line is actually deaths, and we see a pretty stable median age of our deaths that is still mostly the elderly, so over 70 as the median age. And then when we're looking at hospitalized cases, that also has been, there's been a little bit of up and down, but relatively between 60 to 70 years of age as the median number of hospitalized cases. And then the overall cases, though, you can see there definitely is a trend, and as you noted in some of the other early slides, that we are seeing younger median age cases overall. So now our median age is actually in the 30 to 40-year-old range. Next slide. And then this is just another way of looking again, and I realize these the county names are too small for you to see on this slide, but the cumulative incidence rate. So again, this is per population, not just the total number of cases by county. And Imperial County by far has the biggest incidence rate, and there's been a lot of border issues with that, but that has caused a strain on our healthcare system statewide. So we've been doing a lot of mutual aid and transporting patients to other parts of the state because of the huge burden in Imperial County. And again, on our website that I showed you earlier, you can see these numbers as well. Next slide. And then this is looking at a trend, again, because there's some ups and downs, from day to day, trying to look at a trend over 14 days and looking at the most recent block of time. So June 26th to July 9th for a 14-day trend. Pretty similar, but there, you'll see some changes sometimes over time with the different counties. Next slide. And then looking a little bit more at some of the demographics and ages, just a few highlights I wanted to point out here. This is some of our internal data that we're reviewing. So, again, I highlighted and mentioned, but as far as what are the percent of cases, we're seeing an increasing number of cases diagnosed in younger. So the largest proportion in the 18 to 34-year-old range, and then 25% in the 35 to 49, and 14% in the 50-59 age range. So seeing that trend in a large predominance in that younger age range than what we were seeing early on when we were testing more of the elderly and more of the hospitalized. And similarly, we're seeing more of that in the hospital. So while there's still almost 18% of our hospitalized cases are in over 80-year-olds, there's also 18% in our 50 to 59-year-olds and our almost 17.6% in the 35 to 49-year-olds. So that is definitely a trend that we're seeing. And as you can see in the percent ICU, there's also some concerning high proportions of 35 to 49-year-olds and 50 to 59-year-olds in the ICU. And then death-wise, we're still seeing a trend in the elderly. Looking at the other gender demographics, it's still about 50-50% as far as the percent of cases, but we are seeing more of a trend of predominance in males hospitalized, 55% versus 44.6%. In hospitals and in ICU, it's even a higher proportion, 63% in the ICU. And then death-wise, there's also a higher proportion of males that are a proportion of our deaths, 56%. Next slide. So just to kind of summarize some of the trends here, what do we think is driving this transmission? We think a lot of this is just with the lessening restrictions. And again, Dr. Chen started to mention this. And I think I will say from my perspective, both local and now thinking about this statewide, I think we certainly anticipated there would be more cases with the lessening restrictions, but we had no real way to predict the rate of rise or rate of new cases. And we're certainly concerned with the trend that we're seeing now. But just as people are out and about and mixing more, and that's where we, again, are really happy to have this opportunity to work with you from the public health perspective to help us get these messages out about all the things we need to be doing to keep each other safe and mitigate disease in the community. And on that note, I think really what we're seeing a lot of is essential workers who have been working the entire time. So even during the stay-at-home orders, we had a lot of workers who couldn't work at home or stay at home. So, and especially in high-density neighborhoods with really crowded living conditions, we're seeing a huge predominance in our Latinx population of cases, and Dr. Angell's going to go deep on that and highlight that much further later. But we are very concerned about that population as a huge driver of disease transmission. And of course, as you've been hearing about and as anticipated, we are having ongoing outbreaks in nursing homes, which of course have the unfortunate combination of not only really easy to spread in the nursing homes and high severity as far as the age there. As again, we know that the seriousness of this disease continues to be the higher the age, the more serious potentially illness. And then in prisons and penitentiaries, everyone I'm sure is familiar with the San Quentin outbreak and the huge impact that's having on the Bay Area and statewide. We are seeing more and more workplace outbreaks as well. So again, essential workers for sure, and as more things are open, we've seen construction outbreaks and really trying to work on that area as well as far as working on enforcement and working with partners to enforce using physical distancing and face covering and other mitigation efforts in the workplace. We're seeing more of that. And certainly, again, more testing. As we test more, we're going to find more cases, which is what we need to do to then try to isolate and quarantine contacts. And over time, especially now, some of the announcements today that Dr. Galley is doing simultaneously are really about prioritizing our testing and targeting to the highest yield of case finding as we hit some limits on our testing capacity right now and these really long turnaround times. And then the Imperial County story, I think we really do think is reopening with Baja California and a lot of the disease transmission back and forth over that border. And as I mentioned earlier, we are very concerned about compliance with physical distancing and face coverings. And this is really a huge area of really changing behavioral norms and getting our public to realize that we are, as Dr. Chen was saying as well, this is going to be COVID is with us for the foreseeable future, and in order to continue to try to resume some of our other activities, we really need to use all these measures that we can. These are our limited tools in our toolbox to mitigate disease in the community. So physical distancing and face coverings, and it certainly seems that a lot of our population is not yet ready to embrace that and really comply with that. And we need a lot of, I feel, community on the ground leaders to really change our norms around that, in addition to doing what we can to enforce that. Next slide. So in closure, I'd say, as emphasized over and over, we are seeing an increase in trends in new cases that is very concerning. Also a trend in our hospitalizations, and starting to hear from some of you in our hospitals about some strains that are starting to be of concern. And then the percent positivity trend is also increasing here in California. And it's really been, I think, most dramatic over the last 3 weeks. The new death rates may be decreasing. Again, we are looking closely at these trend lines and the epidemic curves of the actual dates when people are dying, and trying to get a handle on whether that's actually decreasing despite the other things increasing, or if there's just a time lag with that. We do know that's typically a lagging indicator. Again, cases are more commonly seen in a younger age range, more recently 18 to 49-year-olds. The hospitalizations and ICU stays are still more among persons aged over 50, and the deaths are more common among persons aged over 60 and relatively stable. The cases are similar between males and females, but certainly seeing higher morbidity in hospitalization, ICU, and deaths among males. And then last thing that's not on this slide, but just to say again, we have some of those thoughts about the transmission, but in one of my new roles here too, really want to work closely with our locals to better understand our exposures as well and continue to understand what's driving transition and try to target that. So with that, I will turn it over to Dr. Green.
Thank you so much, Dr. Pond. And I just want to mention, because we're moving towards 1, some of you may have to drop off, but we will be going till 1:30. We're going to have Dr. Angell start right now, and then we'll have some Q&A. So if you can't manage to attend for the full thing, know that it will be recorded. So Dr. Angell, thank you so much for joining us. Are you there? Dr. Angell, it looks like you're still muted. Oh, there you are. Still muted, I think. Let me try your sound. I see your video. Can't hear you yet. Technology. Oh, does that do it? Still can't hear you.
Can you hear me now?
Yes, well done. Thank you.
Well, terrific. Well, thank you, Dr. Green. Thank you, technology, for working for me today, and thank all of you for joining us for this Grand Rounds. Really very honored to be a part of this today, and to be a part of this team here in California working to address COVID-19. So you can go ahead to my slides. So I'm going to focus in on a very specific area, which is health inequities. And given the limited amount of time, I'm going to focus in largely on race ethnic disparities. But I want to acknowledge that absolutely across the board, we are seeing and expect to have disparities across a large breadth of different populations, including, for example, older adults, LGBTQ community, people with disability, immigrants, those who are uninsured, those who are disadvantaged in many aspects of society are likely to experience health inequities. But for the purpose of this presentation, I'm going to share with you a deeper dive. And so to do that, I'm going to focus on race ethnic disparities. I'm going to start by defining health inequities, not because I don't think that all of you likely on the phone are aware of health inequities, but I also think that it can be defined in many different ways. There's no correct way, but perhaps for level settings for the purposes of this presentation, I'm going to provide some definition. Then I'm going to talk about the inequities that we do see through the lens of COVID-19 in our populations, and then a bit about the California's response. Next slide, please. So first of all, the key thing that I want to raise up is that oftentimes people use disparities in health inequity, those terms interchangeably. But for many, and in many of the definitions as we talk about it, there are distinct differences. I'm providing the definitions here that are used by the state of California through our Office of Health Equity, which is an office that was created by law here in the California Department of Public Health. And it's very clear that as we talk about disparities are really differences that we see in prevalence and the incidence or severity of diseases amongst segments of the population. So it's just a description of a difference in outcomes that we might see. Inequities, however, are really disparities or that are differences that are observed in health or mental health or other factors that shape health that are systemic and avoidable and therefore considered unjust or unfair. And when we talk about work, when we talk about our focus, it's when we see those patterns of disparities that we then start to look very closely to see, are they indeed part of and being perpetuated by systems that we have? And if they are, those are places where we really target our efforts, because when we're able to uncover and change systems that are creating disparities, which are therefore inequities, we are actually able to change the destiny of large groups of populations, and we are able to address injustices that exist. And that's very clear and a part of this administration's commitment, and certainly as providers, an area that we've focused on much of our work in general throughout our careers. I think all of you would recognize that. Next slide, please. And many of the systems that we talk about that are responsible for creating these health inequities The so-called social determinants of health or determinants of equity include social, economic, geographic, political, and physical environmental conditions. Those become very important as we talk about the disparities that I'm about to describe for you. And so I'm putting these up here for us to all think about that within context as we look at what's happening, particularly within our communities of color in California. Next slide, please. I wanted to first acknowledge that while much of our energy now is focused on what is happening specifically during the pandemic, there are definite disparities that existed before we went into the pandemic, and they indeed are defining the trajectory of what we're observing in populations in our communities. We in California were prepared for this. We were thinking about this even before we had the data. We were starting to roll out programs that acknowledged that certain populations would be affected differently, and we were targeting those very early. But it's important to notice that all of those disparities that we're seeing now are not necessarily new. They're just heightened by COVID itself, which is basically unmasking them. So for example, when it comes to life expectancy, by race and ethnicity in California, we know that in 2018, life expectancy for Blacks was almost 12 years shorter than it was for Asians. That is 76.1 compared with 87.9. Next slide, please. And so as we moved forward through our work in looking at addressing the pandemic, it wasn't actually until in April when we had clear data that showed us what was happening with respect to race ethnicity. So we had our first cases in January. We went into our stay-at-home order on March 19th. March 19th, the number of cases that we had in California was 675 cases. By April 8th, when we had numbers large enough to be able to report out and think through what the implications were, we had a total of 16,957 cases. That's when, in April 8th, we first published this data. And now to date, as mentioned, we have over 336,000 cases in California. So the growth has been substantial, as is our understanding of health disparities over time through COVID-19 at this point. Next slide, please. So let me share with you a little bit about what we've found here in California, and I'm sharing with you the data to date. So this is reported out yesterday, July 13th. The data comes from July 12th, and this is a table that we put on our webpage daily that shows race ethnicity for cases and for deaths. So I want to point out a few things here. The first thing here is that at this point, if you look at the percent cases, whites make up about 17.7% of all cases in California. When all is said and done, this is going to be a conversation really about race, ethnicity, and the way in which COVID-19 has really moved within our communities of color. That's a really important point for us to think about now early. It's also going to be a very important point when we think about this in a year as we're rebuilding structures to try to address what is clearly inequities that are being defined by systems and structural issues here in California. The second thing I want to point out are the differences, and I've just highlighted a couple of race ethnic groups, Latino and African Americans in this first slide, of the percent deaths, the percent cases, the percent deaths, and then the percent of the percent they make this population, each race ethnic group makes up in the California's population. So for example, with respect to Latinos, they make up 54.8% of all cases, and yet they only represent 38.9% of California's population. And our community of Latinos represent 43.8% of deaths, again, comparing it to 38.9% of the California's population. When we look at African Americans, we see that the percent of cases, 4.3% that they make up of total cases, is actually lower than their percent of the population in California. But the percent of deaths that they make up is higher than the percent of that they make up in California. Now, when we first looked at this data and we looked at this table overall back in April when we presented this, we started looking very carefully at these tables. In fact, one saw no differences by percent death or race ethnicity by percent of cases, percent deaths, or percent of California's population by race ethnicity. We saw virtually no differences. But clearly, over time, this has emerged. I'm going to show you some more data that shows how it emerges. But the other thing that we did was that we thought, well, wait a minute, let's just see if some of these differences are being masked by age. So I'm going to show you one slide that we also put up daily. Next slide, please. That looks specifically at younger adults, those ages 18 to 34 by race ethnicity in California. And what you'll see here is a pattern that has been persistent and that we uncovered by looking by age strata. So here, Latinos make up 57.3% of all cases. And in this age cohort, 45% of California's population. And you see their deaths increasing within our Latino community at 64.2%, making up 45% of California's population. In African Americans, again, you see that the percent of cases is lower than the percent population that they make up, but the percentage of deaths is much higher. In fact, 2.3 times higher than the percent population that they make up. So we're seeing by age something going on here that's very different in our younger communities of color than one would see just looking overall. Next slide, please. So this slide helps us look now a little more closely by race ethnicity using incidence by age group. And in this slide, I think it's important because it helps us understand what's happening within some of our populations, which make up a very small percent of California's population, in particular, the Native Hawaiian and Pacific Islander population, which makes up less than 0.1% of the population. And yet here, when you look at it by incidence, you see much higher incidence within this group than you see across other groups as well. And that is across virtually all age groups, starting greater than 0 to 17 years of age. So this again helps us understand a little bit more about what's happening within some of our race ethnic groups here in California. Next slide, please. And this slide helps us look a little more closely at race ethnicity by age group, incidence by race ethnicity and age group by month over time. So in this slide, March is the gray bar, April is the gold bar, light blue is May, and June is green. And so I'm just going to draw your attention to the left upper corner to look now at the very younger population, the 0 to 17 age group. And three things I think become very apparent here. One is that the incidence has been increasing across all of our race ethnic groups over time. But what we see in particular is within the Latino community, in our community is a much higher increase in the months that ensued, and particularly in the month of June, and we expect similarly these incidents to continue to increase and at a much higher rate in Latinos in the months that in this next month as well in July. Next slide, please. So what is causing this? And I think that Dr. Pan touched on a number of these, but I think some of the key things as we've been looking through these clear key risks for exposure include things like our essential workforce. So we know that 70% of the essential workforce is made up by people of color, a much higher percent. The essential workforce during our stay-at-home order was the workforce that continued to work. And so therefore, of that workforce, the ones that continued to go into the community were the ones who couldn't work at home. And so what we saw and what we are continuing to see is a disproportionate number of cases within a number of our essential workforce environments, including agricultural workers and in manufacturing plants. We're seeing outbreaks in those environments. So clearly the essential workforce being a part of it as a person of color increases the risk for exposure. Other things that increase the risk for exposure that we think relate to some of these disparities that we're seeing are, for example, outbreaks and cases that we're seeing disproportionately in multi-generational households, where there is more dense living, and also where some of the relationships, for example, in our Latino community, some of our greatest strengths, the things that bring us resilience are large, expansive families and tight-knit communities. And yet during COVID-19, that very aspect, which brings strength to our community, is also something that puts us at risk for exposure because the families are so close. And what also ends up happening are these gatherings. And gatherings in the state of California under order are not allowed. And so we're seeing groups of people coming together. Oftentimes when people are familiar with each other, they are non-adherent to our non-pharmaceutical interventions like face masks and physical distancing, which also increases the risk for exposure. And then finally, as touched on also by Dr. Pan, some of the congregate settings where we also know there's a disproportionate percentage of people of color are having specific outbreaks, particularly in our prisons and jails, which we've seen more recently, skilled nursing facilities, also where we know that there have been higher rates in those facilities that have a higher percentage of people of color, and in other congregate settings as well. All of these in sum create this environment where communities of color are being exposed at higher rates, contracting COVID-19 at higher rates, and also we're seeing higher deaths as a result in these populations. Next slide, please. I also think, just want to note that while we're talking about deaths and cases as a single event of exposure that then progresses to untoward outcomes in specific environments, that the likelihood of higher cases within these communities is the product of generations of injustice and disadvantage that's led also to comorbidities that we know put people at greater risk for severe outcomes from COVID-19 that are disproportionately higher within many of the populations where we're seeing higher rates of death. So while these comorbidities help to explain the higher potential for death, they don't necessarily, in and of themselves, they aren't necessarily the target for a solution. The solution is really thinking about what has caused disproportionately high rates. And that includes, as we look at asthma, diabetes, heart disease, obesity, and high blood pressure, which I have on this slide here, in adults greater than 18, and then also in adults greater than 65. You'll see that there are disproportionate rates in those populations where we're seeing these higher rates, particularly of death. Next slide, please. I want to emphasize also that while we've been talking specifically about the direct impact of COVID-19, I've been talking about the direct impact of COVID-19 in this presentation. There is also the indirect impact of COVID-19 through the types of measures that we've had to put in place. And for those populations that are disadvantaged to begin with, Latinos are less likely to have a primary care provider or have access to care. For example, those combined together can create conditions that further exacerbate the negative impact on health that these communities will have that are not reported just through the number of cases of deaths related to COVID-19. But certainly as we're looking at the potential for higher morbidity related to preventive care delays, chronic disease management like diabetes, lack of access to services related to mental health and the impact that isolation has on communities, exacerbating mental health conditions. Ultimately, these communities also will have a much greater burden of these as a result of COVID-19 as well. Next slide, please. So what is California doing? So as I mentioned to you very early on, we had already anticipated that these types of challenges would exist disproportionately for specific communities. We've been working very hard, in particular, more recently, as we're seeing these multi-generational outbreaks, to do much more outreach. And this is some examples of what we've been doing in the Latino community in particular, and that is developing education materials. For example, really trying to reach this community to make sure that kids are brought in for their routine pediatric visits to make sure that their shots are up to date. We've seen a decrease of 40% in shots in their vaccines that kids have received this past April as compared to the April before. And so we really have to do a lot to try to really increase rates of vaccination and immunity to be sure that these communities aren't disposed then to even greater impacts as a result of our interventions around COVID-19. We've been doing a lot of work around social media with billboards, radio and TV, podcasts, and using public service announcements as ways of reaching out to these communities. And we're developing more and more collaborations with community-based organizations and other trusted messengers to make sure that we can reach these communities. But there's so much more we need to do, and we really look forward to ways to collaborate with any of all of you who are really on the front lines of treating these patients and may have ideas for ways that we can be more effective in our outreach. Next slide, please. Some of the things that we're doing, for example, for agricultural workers, which I mentioned to you, we have higher numbers in a number of areas like the San Joaquin Valley, for example. We've done things like mobilizing mobile van testing to be able to bring the test to those communities to make it easier so that testing can be done in a way that's expeditious and much more accessible, and that follow-up can occur then. We've also created something that is sort of a model based upon Project Room Key, which was designed by California to help house the homeless during this time. We are likewise making rooms available to agricultural workers who may test positive and don't have a place where they can isolate safely from others because of crowded housing or conditions that makes it just impossible for them to be able to protect others that may be in their household. And so we've been using mobile homes and hotel and motel housing to make that space available to those workers at no cost. We've been distributing face coverings also to make sure that this population has access to them, and as well doing a lot of health education, collaborating with community-based organizations and our 10 migrant centers across the state to make sure that the information gets directly to these communities at the time that they need it. And as well, we've been providing guidance documents. These are documents for both employers and for employees. For those workers themselves to help educate on how to isolate safely, how to protect yourself from COVID-19, how to think about using and how non-pharmacologic interventions regularly in one's life, and then lifestyle, and then as well for employers, really helping them to understand what resources are available and how to organize the work environment in a way that reduces the risk to this community as they're working. Next slide, please. And then for our essential workforce at large, a lot of work has been developed, and we are ramping up this work further. This includes Cal OSHA guidance to help protect agricultural workers, people who are working in logistics, where you have and groceries and healthcare workers, all of those on the front line, not exclusive to our communities of color, but recognizing also that communities of color make up a very high percentage of this population. We do expect it to have impact as well in helping to reduce risks in these communities. There have been also very focused types of policies like food worker hand washing breaks. So really targeting in on things that are unique to specific communities and making sure that, for example, there are breaks every 30 minutes for by executive order that allow workers at food facilities to wash their hands. So we tell people to wash their hands frequently. We need to make sure that we engineer that space into the work environment to allow people to really adhere to those guidelines. I'm also really thinking about how important wages in this community. So somebody becomes sick without sick leave, the option may not exist for that person to stay home without really risking their financial stability, which is a problem and has a knock-on effect in many other areas of health. So there's 2 weeks of supplemental sick leave available now for certain food workers, which includes farm workers, restaurant workers, and other grocery store workers, helping both those individuals, but also making sure that they don't expose others. It can use this as a mechanism to not expose others and also reduce the likelihood of spread within a workplace. And then COVID testing, of course, throughout the state is being made available at no cost to the individuals. Next slide, please.
Sorry to interrupt. We are getting near the end of our time, so if you can wrap up just so we have time for a couple questions. So many great ones. This is great stuff.
Yeah. So really, I just want to emphasize then that really our communities that were at greatest disadvantage pre-pandemic are really carrying the burden of COVID-19 through this pandemic itself. And as it reveals cracks in our structures and challenges our systems, I think really the opportunity now is to rebuild them in ways that undo the biases that have perpetuated these unjust and unacceptable inequities in health and also beyond. Thank you.
Great, thank you so much. So hang tight, please, Dr. Angell.
Dr. Newell Green, we're getting a lot of static.
CME, you'll receive a survey after this afternoon, so respond to that email and you'll get your certificate of attendance by the mail.
Dr. Newell Green, would you mind repeating what you said for the last minute or so, just because the sound was a little bit off, please?
Oh, I'm sorry. Tell me if that's not great. I thank Dr. Angell, and I wanted to say that we wanted to do a final survey to get your feedback on future topics. So if you guys can release the survey. And it's there, these areas are areas which we've received tons of questions on, and we will have opportunities to look forward to these topics and more next one coming up on August 11th. Go ahead and choose your topic. And then again, just as a reminder for all of those who are interested in receiving CME, you'll receive a survey this afternoon. So respond to that email and you'll get a certificate of attendance via email. All right, how are we doing on the survey? Okay, looks like we have a wide range. People are really interested in clinical updates and then reopening schools, so medication updates, PPE, and congregate settings. So I will say that among our questions, there were a lot of questions in many areas. Schools was absolutely one of them, and this is a particular area of interest to me when I've been doing a lot of work on, and I really hope that we can find safe and equitable ways to open our schools as quickly as possible. I don't know if anyone in the group can comment about how that's being thought of on a state level. People are asking questions about how and when we can feel safe as a community to open schools. Your county might have increasing number, but you might be in a smaller part of the community where there aren't really a lot of disease cases. The data in pediatrics really shows that kids don't have a lot of disease and don't transmit a lot, but how do we make those individual decisions, and can those decisions be made independently from many of the other services we're closing? So does anybody want to, maybe Dr. Chen, have a quick comment on that?
Sure, I'll make a comment and then turn it also over to Dr. Angell, who's been really involved with many of the guidances. I would say, as with many things with COVID, we're trying to be evidence-based, and that evidence is still coming in. There are a lot of considerations between, again, this idea of balancing the health and safety of both our students, learners, teacher community, and family members, particularly kids who live in multi-generational households, and then the benefits, the absolute benefits of opening schools, particularly in the setting of a lot of the data that's coming in terms of kids being at less risk of contracting COVID and being the primary transmitter. So I think, again, a lot of this is going to be played out over the next several weeks to months, and we're actively in conversation with the counties as well in terms of coordinating what we do. Sonia, if you want to add anything, please jump in.
Yeah, no, I think that you hit all the highlights. I would just emphasize that the decision about schools is an inherently local decision. We really work closely with our local health officers because they are, on the front lines. They do have a very good understanding of what's happening across the county, and if there are specific outbreaks in settings that would raise caution around this. So this conversation is a state conversation, but very much in close contact with the locals that ultimately make the decision.
Great, thank you. We also received a lot of questions about testing, and I know, Alice, that you had said Dr. Galley is talking about that today. I don't know if you can or want to give us any highlights. People are really hearing that now we're having increased wait times for tests. Why do we still have testing issues this far into the pandemic? And is the state considering reconstituting the statewide testing task force? This is, again, an area with so many questions here that I think it's one we'll address in detail at a future installment. But can we possibly have a comment about that from either of you?
Absolutely. So I think, you know, as you saw, I think on one of Erica's slides and the numbers, we've done a tremendous job in ramping up from 2,000 to more than 100,000 tests a day. The problem is that there are surges across the country now. And so frankly, the major companies, whether it's Roche or Abbott or Cepheid, just have a supply-demand mismatch problem. And so what we're finding is, in fact, that the, you know, all along during the pandemic, we've had supply chain issues of various sorts. At this point, swabs are not an issue. Machines are not an issue. It's the reagent kits. The viral medium is not an issue. At one time or another in the past, all of those had been limiting factors. We addressed them. The testing task force, which actually is still in existence, had addressed those one by one. At this point, it's the reagent kits, and we have been in contact with Roche. We've been in contact with the other companies, and unfortunately, they can't manufacture them quickly enough. So, you know, our science branch is looking at other different strategies in terms of pool testing. There are a lot of considerations and barriers there, but it is definitely an issue that we are well aware of and are trying to address. There are only so many things we can do in the global scheme. So the testing guidance, which Secretary Galley is rolling out today, really is trying to help set priorities in terms of who should be prioritized for testing and turnaround in the setting of our knowledge that we're not going to be able to test everybody we want as quickly as we want.
Yeah, that's such a tricky one. Okay, I think this is the final question we have time for today. There's so many robust ones, and I'm really hoping that we can find a way to use this forum as a way really to feed questions back to you in public health. And this question is really about the public health community, and then find some great way to get all of our questions answered, because I know that many of us are sitting in offices and facilities just with lots of questions. So anyway, one of the people who wrote in said something I'd really like to echo, which is that we've really been horrified to see the reports of public health officers and you all getting threats and needing security. And we just want to really, the speaker did, and I do too, or the writer did, thank you so much for working so hard to protect us in the public. And we would, this person and I would echo, would love to figure out a way to help better support you. There also is the other side of that, which is that there's only so many of you, and there's so many of us and other people requiring your time and attention. And it's, for many providers, been sometimes hard to both get public health officials on phone or find a way to contact to answer questions, or to do contact tracing and things like that, getting timely responses. And I know that you live at the state level, and Dr. Pan unfortunately had to go away from another meeting because she had been at one of the local levels. But if you have any comments just in general about those wonderings.
Yeah, this is Sonia. I just want to thank all of you for acknowledging that, particularly because your local health officers are working 24/7 in the community and often don't get that positive reinforcement. So I think, you know, first of all, just remind all of us as physicians that we are very, very highly trusted messengers in our communities. So the opportunities, any opportunities that you have to really lift up the voice of the public health officer, to lift up the science, and to reinforce how important many of these policies and activities are, is going to make a difference. It's going to help lighten the load for the public health officer. The second thing is just, I would say, patience at this time. Also, in the midst of a pandemic, it's very difficult for people to respond in a timely manner across the state. The local health officers are working very hard to be responsive, but I also realize that people are stretched very thin. So to the extent that resources are available on websites and can be accessed that way, encourage you to use them, encourage you to reach out and share your comments of support, and explore ways in which you might be able to extend the work that they're doing. If there's ways in which you can be a collaborator, I'm sure that they would very much welcome that. And it also comes to reinforcing messages around testing that you just gave, for example, just being aware of what the guidelines are and really helping to reinforce those same guidelines in your own practices.
Great. Well, I just want to do a final thank you to the two of you who remain, Dr. Chen and Dr. Angell, for your work and then being here today. And we'll thank Dr. Pond separately. Again, a thank to all of the wonderful people in the background organizing this and helping it go smoothly, as well as the planning committee. And as we're on the final slide that tells us what our email address is, I'll also mention that the website covidaroundca.org is just the very beginning of a website on which will be posted this video and future videos and perhaps other content that comes out of these experiences or this speaker series. But please do email us with questions, comments, and concerns in ways that we can support you in the really important work that you're doing, both as providers and also as citizens, part of developing this new social contract we all really have to sign up for to keep each other safe. So with that, I think that I'm going to wish you all a happy Tuesday, and we look forward to seeing you in a month. Thanks very much.